to introduce the cervical deformity section now. And we're going to begin with a great talk by Adam Shimer on so many numbers. Which are the most important ones?
Good morning. Quick show of hands, who routinely measures global spinal alignment or spinopelvic parameters on their patients? How about cervical alignment parameters, sagittal cervical alignment parameters? Because my sense is we're probably about 10 years behind lumbar or thoracolumbar alignment than we are cervical spine alignment. So what we're going to talk about is basic concepts, analogy to global spinal alignment, because you see a lot of the same threads and themes between the two. What to measure, what is normal and thresholds for abnormal, and how does that drive your care of these patients. So the basic concepts of cervical alignment, and I think we all kind of have a gestalt for this even before we started looking in earnest, is that lordosis is good, kyphosis is bad. You want to hold your head over the cervicothoracic junction. You want to be able to look straight ahead, so you want to be able to maintain horizontal gaze. And you want to have your cervical lordosis matched to your T1 slope. So we're going to try to drill down into each one of those goals and see if we can't get a little bit more nuanced with evaluation of that. So my analogies between the neck and the entire spine is that lordosis is good, kyphosis is bad. So you see that with spinopelvic parameters too. You want to keep your head over C7, or you want to keep C7 over your sacrum. You want to be able to maintain your horizontal gaze, and you want to have your lumbar lordosis matched to your sacral slope. So when you start to kind of draw these analogies, it gives you a good framework to work within. So looking at it first, lordosis is good, kyphosis is bad. This one's a fairly simple one to measure. It's a C2, C7 Cobb angle. You measure it from the inferior end plate of 2, inferior end plate of 7, and the angle subtended between those two lines. You want to keep your head over C7, so we want to look at the cervical sagittal vertebral axis. Very similar to the sagittal vertebral axis looking at C7 over the sacrum. You're going to drop a plumb line from the mid-body of 2 and measure it to the back superior corner of 7. One of the issues is we don't really know what normal is yet. I think with global spinal alignment, we have a little bit better assessment of age match normal. Cervical spine, we're not quite there, but closer to 0 is better. And we have pretty good evidence to show that anything greater than 4 centimeters is our threshold for abnormal. You want to be able to look straight ahead. So you can measure this a couple different ways. I think the best way to measure it is the chin-brow angle. So you measure a chin-brow angle to a plumb line to vertical, but it's sometimes tough to measure. I was just looking through a bunch of my cervical spine x-rays. You essentially never see the anterior aspect of the skull on them. So a good alternative is the McGregor slope. And this is the chin-brow angle here. The McGregor slope is measured between the hard palate and the opistheon. So essentially where the top teeth are and the back of the skull. And you want to have your cervical lordosis match to the T1 slope, and these are some pretty elementary pictograms to show. The one on the left is a fairly normal alignment. You can see if you're lucky enough to have a flat cervicothoracic junction, you can have a very straight cervical lordosis. But if you have this exaggerated thoracic kyphosis, you really need to have a high compensatory cervical lordosis. And I think it's similar to a sacral slope. Some people can have very little lumbar lordosis to maintain their global spinal alignment. Some people need a very exaggerated lumbar lordosis. So if you look right here, this is a patient that I had recently seen, and she has very exaggerated thoracic kyphosis, and because of that, she needs to have hyper extension or exaggerated cervical lordosis to maintain her horizontal gaze. So what happens when your cervical lordosis is mismatched to the T1 slope? What happens is you can't look forward. So essentially, your takeoff of C7 is more anterior. You don't have the compensatory lordosis, and you can't maintain your horizontal gaze. So when cervical lordosis is mismatched to T1 slope, You want to evaluate this by the T1 slope cervical lordosis mismatch, similar to the pelvic incidence lumbar lordosis mismatch. In the cervical spine, we want that to be less than 17 degrees. That's the threshold for normal. The threshold for abnormal we believe to be anything greater than 35 degrees. So what happens when you have this mismatch and you're staring at the floor? Well, one thing you can do is you can extend through your occipital C2 joint. And you can see this here, and this is that same patient. And if we kind of focus down here to the C1-2 joint, you can see there's an erosion, and you often see this with the back ring of 1 rubbing against 2, so he's extending through C1-2 in the occipital-cervical junction. So we've talked about these different parameters. It would be great if there was a single measurement that was easily visualized, easy to measure, and we think that might be the C2 slope. And it's similar to L4 flat to the floor, right? So I always tell the residents, like if you look at anything, if you just look at lateral x-ray, if L4 is flat, everything else usually kind of goes along with that. And the same thing, you want C2 to be flat to position your head over the cervical spine. And it's a benefit of a single angle. It's sometimes hard to see T1. It's sometimes hard to see the hard palate or the chin-brow angle. So you can see this is a relationship between C2 slope with clinical outcomes. C2 slope is easily measured, and it has a good predictability measuring health-related outcome measures. And the receiver-operator curve shows very similar characteristics between C2 slope and both the cervical sagittal vertebral axis and the cervical lordosis. So C2 slope less than 10 degrees results in improved clinical outcomes at 3 months. So putting it all together, you don't want to take too much time in clinic. So for global spinal alignment, we measure SVA, we measure lumbar lordosis, pelvic incidence, pelvic tilt. I think that usually gives you a pretty good assessment. There's certainly other things to measure, but if you can look at those, it gives you an idea of their global spinal alignment. So the basic cervical, that's for the thoracolumbar spine or global spinal alignment. For the neck, lordosis is good, kyphosis is bad. You want to keep your head over C7. You want to be able to maintain a horizontal gaze, and you want to have a matched cervical lordosis to your T1 slope. So all you do is you plug in each one of those values that we looked at and we talked about. So I would measure a C27 cob. I'd measure a cervical sagittal vertebral axis. I would get a McGregor slope, and I would do a T1 slope cervical lordosis mismatch. And then maybe the easiest of all of them is just measure the C2 slope. So my rule of thumb or cheat sheet, we certainly have a much better idea of what to do for global spinal alignment, but I think you want to keep your cervical SVA less than 4 centimeters. You want to be able to maintain a horizontal gaze, so a McGregor slope is 0 or a chin-brow angle of 0. You want to have a T1 slope cervical lordosis mismatch less than 25 degrees. And I think a really easy one is if you have a C2 slope less than 10 degrees, they have a well-compensated cervical sagittal alignment. So it's one easy one that you can just measure. So this is a patient with a pretty significant deformity. And I just measured all the angles here. So C2, C7 cob is minus 31. They have a cervical sagittal vertebral axis of 11. McGregor slope is of 43. They're looking at the floor. T1 slope is 64 and the mismatch is 95. So clearly a deformity that could be addressed. That's it. Thank you.
I have one for Hanjo. So I enjoyed your talk and the selection of UIV, LIV, and the classification system. One of the deformity types that doesn't fit so nicely into that classification is a dropped head, because it can look rigid in a flex-X unless you put the patient supine. So technically it's like a cervical thoracic junctional deformity, but if it's truly supple and flexible, do you have to go pretty low in that case, or can you stop up at like T2 or something like that?
I mean, I think if you have somebody with a dropped head, I'm guessing like the T1 slope's pretty high, their C27 is really elevated, and their cervical lordosis is probably like half of their T1 slope. Is that the patient?
Well, it would be someone who's sagittal backward in their thoracolumbar spine with a low T1 slope. And then the dropped head.
very
brings
high
their
pelvic
neck
tilt.
down. So C2 is really high, like those examples that Chris was showing with high C2 slope,
Yeah.
low T1 slope.
Yeah, I mean, I think, if, in that case, I would probably call it a type 3, and I would go long, like C2 to like past the cervical thoracic apex, and past the thoracic apex down to like T10 or T9, depending on what the radiographs look like.
Yeah.
Yeah,
It's
I'll
always
just
tough to-
add, wherever you go, wherever you pick is going to be wrong. So what's happening is I usually go down to T4 because that's the origin of the semispinalis cervicus, which has most of the cervical extension moment. So I go across that entire area. But what's going to happen is that, those patients, I warn them, there's probably a 50% risk over time that they're going to develop DJK because they've got a underlying muscular problem. And I've sent off muscle biopsies and everything else, and sometimes stuff comes back and sometimes it doesn't. But then you go down, to me, then I go down, the next stop is usually either, the thoracolumbar junction. Some people say you take it to the first couple lordotic segments, and then they seem to pitch forward. So I tell a lot of people that I'm doing a drop head case on, this may be one of 3 or 4 or 5 operations that eventually results in you being fused to the pelvis. So, I have 2 or 3 or 4 of those patients that are fused from C2 to the pelvis because I've slowly marched them down the spine. So we've tried rehab, we've tried, all sorts of different things to do it, but I think it's a fundamental neuromuscular problem, and I think that unfortunately you're at risk of end up doing very, very large cases.
I think the answer was contained a bit in your question for me, is that they had the ability to retrovert, so their lower compensation was actually intact. And one of the things I think we're guilty of, just like we were in Parkinson's disease, is we lump all neuromuscular dysfunction together. And really, my belief is we have to do a much more specific, patient-specific assessment of the exact nature of their extensor muscle dysfunction or their neuromuscular control to try to figure out our termination level. In a sarcopenic patient, age through senescence leads to sarcopenia. I agree with Chris. We've actually been taking those patients down to the pelvis at the index operation when they have a cervical thoracic deformity and they're sarcopenic. But I think it's more complex than just saying, oh, they have a dropped head from a neuromuscular deformity, they need to have this LIV.